So, good afternoon to everyone. I am Atanisia Stufa, pediatric endocrinologist working in Necker University Children's Hospital in Paris, France. And I am the pediatric chair of the thyroid disorders group in the Endo-ERN, with my co-chair Edward Visser from Erasmus Medical Center in Rotterdam, the Netherlands. We're very pleased to welcome you to this joint webinar organized by European Society of Endocrinology, European Society of Pediatric Endocrinology, and Endo-ERN about congenital hypothyroidism and related problems. We have three excellent speakers and experts on the field. Each speaker will give a presentation of 20 minutes, and then there will be a question and answer with a panel and a group discussion session at the end, about 15 minutes. So I would like also to tell that there is a question and answer box that you can see at the bottom of your screen. So please feel free to ask your questions during the session that we will answer at the end of the sessions. And we will also record this webinar that you will find at the side of the European Society of Endocrinology. I would like now to introduce the first speaker, Professor Dominique Louton. So Professor Dominique Louton, he is professor of obstetrics and gynecology. He is the head of the maternity department in Kremlin-Bicêtre Hospital in Paris, France, attached to Paris-Saclay University. And his research topics focused on fetal medicine and specifically on thyroid maternal-fetal disorders. Professor Louton, we would like to hear you. We're very pleased to have you today as a speaker. The stage is yours, please.
Thank you very much for your introduction, and thank you also for giving me the opportunity to speak about my beloved topic. So you asked me to talk on fetal thyroid disorders, which is not only congenital hypothyroidism. Okay, so you will have now the point of view of the fetal doctor, not endocrinologist or pediatrician. So it may be a bit different. Just a reminder before that the thyroid development it begins very early in life and is involved in many genetic modification potentially that of course we don't see antenatally. Congenital hypothyroidism. This was Michel Pollack gave me this slide, just to remind you that what we see in utero is only when there is a hypertrophy of the thyroid gland. So most of the problematic of congenital hypothyroidism escape to our possibilities in utero. So we can only see, of course, coitus. We don't look at atherosclerosis, ectopy, or hypoplasia, even if I'm going to show you some of these cases in utero. So just to go quick to show you how difficult is the problem, there is a continuum between atherosclerosis and hypoplasia, and plenty of genetic conditions have been described, but still escaping to our knowledge. So I'll be more basic. Fetal thyroid physiology. Fetal thyroid concentrate iodine. It begins at 12 GA, and production is only around 18 to 20 GA. What is important is that up to 28 GA, there is a full contribution of the mother thyroxine to the fetus. So it's completely dependent. So it's very important to have a very careful equilibrium in the T4 equilibrium of the mother. If you would think about what you could see for congenital hypothyroidism in utero, well, there is plenty of theoric condition, including those with possible detectable malformation in utero, such as renal agenesia, genitourinary malformation, cardiac defect. But up to date, honestly, we don't have many of the associations described in utero, and maybe one day when things have been more developed, we could find some of these diagnoses. But nowadays, we don't do these diagnoses. So what can we see in utero? If we look at dysgenesia or athyrosis, ectopia, hypoplasia, which are finally the most frequent one with a genetic transmission, we don't see them, except in a few cases. The one we see the best, but which is the lowest in frequency, is homogenesis failure, with a big goiter that even if you don't look at thyroid, you will see it at 22 gestational age. It has also a genetic compound. Afterwards, we have some, I would say, exotic dysfunction, which we never see in utero, which have never been described in utero. We just expect to see them one day. So the most contributive condition is when you have a mother with grave disease and positive antibodies, positive and mostly stimulating, which induce a fetal goiter because they pass through the placenta. Other conditions, such as toxic or iodine overload, have been described, and also iodine deficiency is not inducing a goiter, but more an hyperplasia of the fetal thyroid gland. So you see there should be quite a numerous condition which could lead you to a diagnosis of a fetal thyroid disorder. What you have to understand also is you have to separate the four conditions: the maternal hypothyroidism, the maternal hypo, the fetal hyper, and the fetal hypo. For each of these, where is it? For each of these cases, you can have specific condition. For Graves' disease, for the mother, maternal thyrotoxicosis will jeopardize the fetus and the mother. You can have autonomous fetal hypothyroidism, which will also jeopardize the fetus, but not in such amplitude compared to the one induced by the maternal positive antibodies. So if you look at maternal hypothyroidism, it induces thyrotoxicosis, intrauterine fetal death, prematurity, preeclampsia, IUGR, and also we think now can jeopardize fetal cerebral development. For maternal hypothyroidism, it will induce typically quasi all the pregnancy complications, but at the very lowest frequency. But the main subject is fetal cerebral jeopardize. For fetal hyperthyroidism, it can induce, of course, a fetal death, a prematurity, intrauterine growth retardation, and also some specific symptoms such as advanced bone maturation with craniostenosis, which can have some complication. And for fetal hypothyroidism, the main problem is the goiter and mechanical complication. So how to enter into the diagnosis of fetal dysfunction? Mostly because of maternal hypothyroidism, you will follow up at echographic the fetal thyroid, or you will find it just like a hazard, a fetal dysthyroidism, which is autonomous, but not expecting it. The fetal thyroid etiology for hypo are overload of propylthiuracil, especially if combined with LT4, which is strictly forbidden in pregnancy, congenital hypothyroidism, iodine overload, iodine deficiency, and some immunological mechanism, which I will show you one. For fetal hyper, the most frequent is grave disease with positive stimulating antibodies. I've never seen any other cause of fetal hyper. First of all, you must target fetal thyroid measures. To do it, well, you have to follow up a special condition. At the neck level, orthogonal to the cervical vertebra, you have to find the trachea, make it round just under the cricoid, and then you will see the thyroid very precisely, as I show you here. Here you can see the thyroid. As time is passing by, I must maybe go a little. So you just follow this plan from the neck and the head, go below, just up the heart and the clavicle, you will see the thyroid, just like here. Once you're there, the measures you will make, well, you can make it better if you do some vascular measurement just to see the carotid and the trachea. And then easily you will measure the diameter, just like this, and the perimeter, which is a false perimeter. It's an ellipsoid, just like that. I thank my team for giving me this slide. These are the two main measures we do. We don't do others. We could do, and we will do in some of the studies later, a more specific and precise measurement of the thyroid by making a true perimeter, just like this one, as you can see. Here we are. Once you've done that, if the measures are normal, you don't do any more. It's only when the measures are over the 95th percentile that you will make some vascular expectation. So, all right. Okay. The curves which have been described in literature, they are not much. We've done some. They are like Ranzini in 2001. Others are on less number of fetuses, and we have tested our curves on normal population, and always, as long as you are over the 5th and the 95th percentile, you will have some normal blood sampling at delivery for the perimeter and the diameter. This has been list curves. So you can have also a gross approximation of the thyroid if it's under the width of the vertebra, it's normal, and then you can qualify it as moderate or huge. The mechanical effect of a goiter in utero are cervical extension and liquid excess by tracheal flattening, as you can see there. You will study thyroidian vascularization only if there is a goiter, and you will be able to define a peripheral vascularization and a central vascularization. The one is more likely to be hypo, and the other is more likely to be hyper. How did we find this? Well, we made studies with macroscopic examination. As you can see here, a normal thyroid with an aspect of vascularization of CD34 antibodies and the aspect on the ecography. And you compare it to an hypothyroidism goiter here with very few vascularization inside the gland, just like on histology, and confirmed by various Doppler measurements, either colored, either energy, either what we call on slow flow. And when hyperthyroidia, just like here, you see big vessel inside the thyroid gland, confirmed on histology and on vascular Doppler examination. You can be helped also by the assessment of the bone maturation. It's quite a tricky thing to do, not easy really, but you've got two main points which are Beckler taught on femoral and tibial. with endpoints at different various gestational age. So once you've discovered that you have a big thyroid in utero, how will you make it to be sure of its etiology? Well, you will rely on the level of the antibodies, the stimulating antibodies, varying on different studies with cutoff levels of 2.5 or 5 for the lion study. Over these levels, you can infer that it can be a fetal hyper. If a lady takes a lot of propylthiouracil or neomercazole, it can be also fetal more hypo. Of course, a lady which has had a thyroidectomy with LT4 substitution can only have stimulating antibodies, and this will be automatically a fetal hyper, and so on. A point important is when a lady has a low T4 level just above the threshold. Often the fetus follows the MOVA tendency, and you have to rely to lower the level of propylthiouracil or neomercazole. Other things are peripheral or central vascularization, advanced bone maturation, heart rate above 160. Just remind, if you've got a tachycardia, it is a sign of hyperthyroidism, and it's a late sign and a sign that it can be deleterious very fast. So be very cautious with that. On the contrary, you never will observe a bradycardia with hypothyroidism. I don't know why, but there is no bradycardia and hypothyroidism in the fetus. And also, hypothyroidism fetus are not agitated, but hypo display frequent and jerky fetal movement. So, lastly, if you can't get through, you will have the fetal blood sampling, potentially harmful, 1% of complication, must be in experienced hand after multidisciplinary discussion. Should it be mandatory before in utero treatment? Well, we can discuss of that later, and it's not necessary in more than 50% of cases. Why to treat in utero? Well, to diminish the thyroid size, to avoid cervical hyperextension, tracheal compression, leading to amniotic fluid excess and prematurity and dystocia. For hypo, to avoid cerebral jeopardize, IUGR, IUFD, or delayed bone maturation. And for hyper, to avoid also IUGR, IUFD, prematurity, advanced bone maturation, and craniostenosis, which can have some neurologic problems after, and cardiac failure, which can lead to fetal death. How to treat in utero? Well, for hypo, lowering propylthiouracil or neomercazole administration to the mother, administrating intraamniotic injection for the fetus directly every 15 days, and for hyper, increase propylthiouracil or neomercazole or induce delivery or practice surgery in the mother. So time is passing by. I'm going to show you a few cases. Autonomous fetal dystoria, which is dysharmonogenesis for me in utero. Well, just a reminder on our last study, which is quite old now, which showed that in 15 cases, what you aim to do, you could succeed in lowering the size of the goiter, but you did not succeed to have normal values of T4 at delivery. Remind this. Our last case of dysharmonogenesis was a classic one, FBS at 26 gestational age, TSH over 1,000, T4 and T3 very low. We injected it during each 15 days up to term. And you can see on this slide the size, the diameter, and the perimeter of the goiter, showing that we did not make it go back to the normal, but avoided to have it too big at delivery. And the aspect of the baby at delivery, really a scarce thing at the neck level. And on echography, we could see the same vascularization as seen in utero. Graves' disease, unexpected case of in utero agenesis of a fetus revealed by a grave disease in the mother, showing the asymmetric thyroid gland in utero. This one could be it's the whole story. Graves' disease, which we could not treat by neomercazole, hard to manage, high level of TRAbA, and induced fetal hypo. Finally, we decided to practice maternal thyroidectomy, but unexpectedly worsening of fetal goiter because the antibodies took the hand on the fetus and put him in hypothyroidism. We then gave back again neomercazole to the mother, and we had a successful story ending in normal thyroid gland size and euthyroidin delivery term. Just look at that. This one is fetal goiter at 27 gestational age, treated by propylthiouracil, lowered to 15 because the mother level of a T4 was just above the low threshold, and 15 days of frank regression of the goiter. This one is also quite classic. Maternal Graves' disease, TRAbA positive with propylthiouracil treatment. We treated the fetus with intraamniotic injection of LT4 and reversed, not completely, but quite, the size of the fetal thyroid. We have recently had an expected case, previous child with congenital hypo, mother found to have positive antibodies. Herself, she had hypo under LT4, and it happened, the search for the activity of the antibodies, which revealed to be blocking. And we observed a fetal thyroid shrinking all along pregnancy, and it's an ongoing study. It had predominantly inhibiting antibodies, and we made MRI. This is the case. This is the control. On the case, no signal on thyroid. This thyroid is really shrinking during pregnancy due to inhibiting antibodies. We are expecting the ESE. Submerged part of the iceberg, two conditions which displays also hypothyroidism in utero, Down syndrome. It's not yet published case, but it's quite clear. And iodine deficiency, where we showed that irrespective of term, we had a lowering of the ratio between perimeter of the thyroid and diameter of the head, showing that the more you were deprived on iodine, the more your thyroid was a little hypertrophic. So finally, what we do now is we screen positive maternal mother for antibodies, and this is quite the only open door to make this diagnosis. Other diagnoses are referred because they have just been found unexpectedly. Thank you for your attention. I think it's 20 minutes right now.
Thank you very much, Dominica, for the great talk. We will have some questions at the end of the three presentations.
Okay, thank you very much. So let's proceed with the next speaker, which is Nadia Schoenmakers. She's a consultant endocrinology in Cambridge, United Kingdom, and her academic interest is in thyroid disorders, particularly congenital hypothyroidism and genetic causes thereof. So Nadia, please, floor is yours.
Thanks very much, Edward. I'll just see if I can share my slides. Hopefully that's all right. Super. So thank you very much to start with for inviting me to speak. So I'm going to talk about primary congenital hypothyroidism. I'm predominantly going to focus on causes of congenital hypothyroidism, with just a little bit of introduction about the epidemiology. And it's a really short time to try and fit everything in. So if I've missed out your key paper, I do apologize. It's not because I don't think it's important. It's purely because of time constraints. It's a single conflict of interest. So primary congenital hypothyroidism, the commonest neonatal endocrine disorder, characterized by raised TSH levels and subnormal or low normal circulating T4 levels. And the vast majority of primary congenital hypothyroidism in industrialized countries will be picked up via the congenital hypothyroidism newborn screening programs, whether or not they're TSH-based or T4-based. Primary congenital hypothyroidism is predominantly due to gland dysgenesis, where the thyroid fails to develop normally. Usually it either develops in an ectopic site or completely fails to develop. And then a small minority of cases will have a small hypoplastic gland. Most thyroid dysgenesis will not have an identifiable monogenic cause. But around 5% will have a genetic mutation accounting for it. And these mutations usually involve key thyroid transcription factors or the TSH receptor. The remainder of congenital hypothyroidism occurs with a normally located thyroid gland that can either be a normal size or goitrous, and a much more substantial proportion of these cases will have an identifiable monogenic basis involving genes in the thyroid hormone biosynthesis pathway usually. Gland in situ congenital hypothyroidism can be permanent or it can be transient, where it resolves spontaneously in early childhood. And transient congenital hypothyroidism happens either because of a transient insult in the neonatal period or because of a degree of thyroid malfunction, which means that the thyroid cannot function adequately to meet the really high biosynthesis requirements in the neonatal period, but it can maintain normal basal thyroid hormone synthesis later on in childhood when the biosynthesis requirements decline. The incidence of congenital hypothyroidism is increasing, and it's likely that the reasons for this are multifactorial, and many studies have looked at this, all showing slightly different results in different populations. So with time, TSH immunoassays have improved, and as a result of this, because of the improved sensitivity of these assays, most countries have decreased the TSH threshold for diagnosis of congenital hypothyroidism on the screening program. And several studies have shown that the apparent increase in the incidence of CH is actually due to increased ascertainment because of these decreased TSH screening cut points. However, that's not the case in all populations. So this is a study from New Zealand where incidence of congenital hypothyroidism increased over 2 decades, and this was predominantly an increase in dysharmoniogenesis. Now, the odds ratio for dysharmoniogenesis is far increased in Asian ethnicities compared with other populations living in New Zealand. And the increase in dysharmoniogenesis was completely explained by the fact that there was a much more rapid increase in birth rate in the Asian population in New Zealand compared with other ethnicities in the same country. So this was dysharmoniogenesis that had increased in incidence due to a change in the underlying ethnic balance of the population. And actually the ethnicity-specific CH incidence was stable. In this study from Ireland, the incidence of congenital hypothyroidism had also increased, but it had done so in the presence of a stable TSH cut point and stable ethnicity of the screened population. This was predominantly an increase in mild gland in situ congenital hypothyroidism, and it raises the question as to whether other hitherto unidentified factors such as environmental factors like iodine deficiency or excess, or perhaps improved survival of premature infants may be contributing to the increase in some settings. So what are the causes, the monogenic causes of thyroid dysgenesis? Well, with the exception of the TSH receptor, most of the classical causes involve key thyroid hormone transcription factors. And a key thing to note about these transcription factors is that they're not just expressed in the thyroid gland. And that means that mutations can cause a characteristic spectrum of abnormalities involving extrathyroidal tissues. So PAX8 is also expressed in the developing urogenital tract, and mutations can rarely be associated with urogenital tract abnormalities. FOXY1 mutations are recessively inherited, and they're classically associated with cleft palate, spiky hair, and athyrosis. NKX2.1 mutations are generally monoallelic, and they're associated with a variably penetrant brain-lung thyroid syndrome, where the brain phenotype is usually a benign hereditary chorea, but the respiratory phenotype can be an acute respiratory distress syndrome that carries with it a quite significant mortality, and that respiratory phenotype can affect around 50% of affected individuals. GLIS3 mutations are best recognized in association with neonatal diabetes, but most affected individuals will also have congenital hypothyroidism and then a variable spectrum of other multisystem abnormalities. But it's really important to find the genetic basis for these patients who have congenital hypothyroidism due to transcription factor mutations, because these are multisystem disorders that need multidisciplinary management. In recent years, there are a few new causes of thyroid dysgenesis that have been identified. So at least 4 families have been reported now with mutations in CDCA8 or borealin. Both heterozygous and homozygous mutations have been reported in association with congenital hypothyroidism, usually thyroid dysgenesis. But some older individuals in these families have developed nodular thyroid disease. And this particular individual developed a papillary thyroid carcinoma. So borealin is part of the chromosome passenger complex. It's important for mitosis and cytokinesis, and it's important for thyrocyte adhesion and migration. But recent studies focusing on this papillary thyroid cancer association in this adult have shown that in aged borealin heterozygous null mice, the thyroid gland is enlarged and there's considerable heterogeneity of follicular size. And these mice go on to develop nodules and these papillary structures, and they have a transcriptome readout, which is actually similar to that of papillary thyroid cancer, suggesting that this gene may be involved in thyroid development in babies and children, but may also predispose to tumorigenesis in older individuals. Families have also been reported with both homozygous and heterozygous mutations in TUB1 associated with variably penetrant congenital hypothyroidism, usually thyroid ectopy, as you can see here. TUB1 is involved in microtubule assembly, and in the TUB1 null mouse, the lack of TUB1 results in impaired thyroid development and migration. And you can see that null mice have disordered thyroid architecture and they have impaired T4 secretion. And affected individuals also have a platelet phenotype. They have a variable platelet size, sometimes a thrombocytopenia, and they have macroplatelets on their blood film. And then to focus on the Notch signaling pathway. So JAG1 is a Notch receptor ligand, and JAG1 mutations are well recognized to cause Alagille syndrome, which is a syndrome essentially with a multi-system phenotype, and individuals have a combination of these abnormalities. A study of a cohort of Alagille syndrome patients identified mild non-autoimmune hypothyroidism in 6 out of 21 cases. And then when JAG1 was screened in a congenital hypothyroidism cohort, mutations were identified in 4% of the cohort, usually associated with orthotopic hypoplasia. In a zebrafish model, lack of JAG1 results in thyroid hypoplasia and also decreased staining for T4. More recently, mutations in contactin 6 have been reported in 2 children from 2 separate families. These mutations are inherited in a recessive manner, and contactin 6 is involved in Notch signaling, and these mutations result in impaired Notch signaling. So the similar pathway to JAG1. The contactin null mouse also develops hypothyroidism, and this is a form of dysharmoniogenesis due to decreased expression of some of the key genes involved in thyroid hormone biosynthesis, and there's a decrease in follicular production of T4 in these animals. So then moving on to dysharmoniogenesis. So from the late 1980s onwards, the genes involved in thyroid hormone biosynthesis began to be cloned, and then mutations began to be reported in these individual genes in association with dysharmoniogenesis. And what I've shown here on the diagram is the key genes involved and their key role in the thyroid hormone biosynthesis pathway. And the specific role of these genes in this pathway can sometimes give clues as to the underlying genetic diagnosis when we look at results from the routine tests that we might do in clinical practice when assessing these patients with congenital hypothyroidism. So for example, patients with thyroglobulin mutations often have an inappropriately low thyroglobulin level. And you can see that in this baby here, who has a biallelic thyroglobulin measurement, a big neonatal goiter with avid uptake and a very high TSH, but an inappropriately low thyroglobulin that's right at the lower limit of the normal range, whereas you'd normally expect this to be really high. Individuals with mutations in NIS, which is the iodide transporter in the thyroid, often have apparent athyrosis on isotope scanning. And that's because NIS is the transporter that takes up both radioiodine and technetium. And they have this apparent athyrosis despite clear presence of a thyroid gland using other measures such as ultrasound or the clinical presence of goiter. And you can see that in this kindred here. So these are 4 siblings who all have a homozygous missense mutation in NIS that has impaired iodide uptake in vitro. These children clearly have a thyroid in situ because they have very high levels of thyroglobulin, but on technetium scan, there's virtually no uptake in the region of the thyroid or the stomach, and both these tissues express the NIS transporter. Mutations in IYD cause increased levels of urinary mono and diiodotyrosine because there's impaired recycling of iodotyrosine residues. Mutations in pendrin cause sensorineural hearing loss because pendrin has a role in pH regulation in the ear. And then for reasons that we don't understand, mutations in DUOX2 and DUOXA2 are frequently associated with transient congenital hypothyroidism. And mutations in the genes that I've highlighted in orange in the diagram are associated with impaired iodide organification. And that means that if you do a perchlorate discharge test, you see evidence of an organification defect in these patients. So the genetics and the heritability of congenital hypothyroidism continue to perplex us. And that's particularly the case for thyroid dysgenesis, which I've abbreviated to TD here. So we suspect that there is a greater genetic component to thyroid dysgenesis than is currently ascertained, but it doesn't seem to follow a normal Mendelian pattern of inheritance. So the reason for suspecting that there is a stronger genetic basis than we've currently ascertained are multiple. So firstly, a large French national survey demonstrated that the prevalence of familial thyroid dysgenesis was around 15-fold greater than that predicted by chance alone. We know that the prevalence of thyroid dysgenesis is ethnicity dependent, and thyroid dysgenesis is also frequently associated with other congenital malformations. However, arguments against Mendelian inheritance are the fact that thyroid dysgenesis has an apparent sporadic occurrence in the general population, and there is more than 90% discordance in monozygotic twins. We still haven't managed to completely reconcile these 2 observations, but we've made some progress over the last few years. So the first observation is that oligogenicity is likely to play a role in the pathogenesis of congenital hypothyroidism. So this is likely to involve the additive effects of variants in genes both involved in thyroid hormone development and thyroid hormone synthesis. And these may be variants that have a relatively mild effect on gene function in isolation, but it's their additive effects together that can contribute to development of congenital hypothyroidism. And this oligogenicity may go some way to explaining the variable expressivity and penetrance of the condition. So this is data from a study from Luca Passani's group, where they demonstrated that a cohort of congenital hypothyroidism cases was significantly enriched for likely pathogenic variants in a panel of 11 genes involved both in thyroid development and thyroid hormone synthesis. And many of the CH cases harbored variants in more than one gene. They went on to do some pedigree studies, which really sort of validated a potential role for oligogenicity in the pathogenicity of the disease. Yamaguchi et al. In this study found that individuals with oligogenic CH tended to have more severe biochemical abnormalities than those with a monogenic basis. This hasn't been recapitulated in all studies, but again, it adds credence to the fact that there may be some gene dosage effect in the development of congenital hypothyroidism. And then there have been other case reports that have suggested that genes perhaps not usually associated with congenital hypothyroidism on their own may also modulate the phenotype in congenital hypothyroidism. Then a recent studies highlighted a potential new germline predisposition to thyroid dysgenesis. So this is the only GWAS that has ever been performed in thyroid dysgenesis, and the authors identified a risk locus that was associated with increased risk of athyrosis and thyroid ectopy. And it was a risk allele that was associated with increased expression of genes known to be involved in Wnt signaling in the thyroid. And we know from zebrafish studies that enhanced Wnt signaling can actually result in aberrant thyroid development. And the prevalence of this risk allele was greatest in the Caucasian population, and it's the Caucasian population that has the highest incidence of thyroid dysgenesis. The observation that there is this 90% discordance rate in monozygotic twins has led to a lot of interest in the two-hit hypothesis. So perhaps you need a germline predisposition to congenital hypothyroidism, and then a second, either an epigenetic hit or somatic mutation affecting the thyroid itself or the surrounding tissue to result in the congenital hypothyroid phenotype. And these are results from a study, again, by the Pisani group, which looked at the DNA methylome profile in peripheral blood from 23 pairs of twins, 10 of them monozygotic, most of whom were discordant for congenital hypothyroidism. And in this study, there was one pair of twins that had, where both twins had a heterozygous DUOX2 nonsense mutation, but only one had congenital hypothyroidism. And they found that aberrant methylation of multiple genes involved in congenital hypothyroidism could potentially explain that discordance in phenotype. And then when they looked at the group as a whole, they found that the number of hypomethylated stochastic epigenetic mutations in cases was considerably higher than that in the controls. And these methylation events included genes that are known to play a role in congenital hypothyroidism or thyroid biology. So this adds credence to the idea that this two-hit model or epigenetic events may contribute to CH in some circumstances. So for the final slide, where are we at today? Well, I think we recognize that there are a handful of genes that are robust monogenic causes of both gland in situ congenital hypothyroidism or thyroid dysgenesis. And some of these genes have been identified reasonably recently through next generation sequencing. We also recognize that these monogenic causes cause a much broader spectrum of phenotypes than previously anticipated. However, they still only account for maybe 30 to 50% of gland in situ CH and 5 to 10% of thyroid dysgenesis. Oligogenicity probably plays a role, and again, these oligogenic causes may involve combinations of genes involved both in gland development and hormone synthesis, and they may also explain some of this variable penetrance that we see and the phenotypic variability. Recent studies have given some credence to the two-hit hypothesis, perhaps with a germline predisposition in addition to an epigenetic factor or maybe a somatic mutation contributing to congenital hypothyroidism. But I think a large black box at the moment is the role of environmental factors in congenital hypothyroidism. So for example, iodine deficiency or excess, or the role of endocrine disrupting chemicals such as perchlorate, thiocyanate, nitrate that we know influence thyroid hormone biosynthesis. I think this is particularly relevant because of this increasing incidence in congenital hypothyroidism, particularly the milder gland in situ forms that may be transient. And really the role of any of these environmental factors, either on their own or in combination with genetic defects in industrialized countries, I think warrants further exploration. So I'll end there. Thank you for your attention and look forward to questions at the end.
Thanks very much, Nadia. Truly great presentation. So we discuss indeed at the end. I would like to encourage everyone to already put questions into the chat and please direct them to the speaker you want to ask the question to.
So it's my pleasure now to introduce the third speaker, Professor Paul van Trottenburg. Paul, he's professor of pediatric endocrinology in the academic medical center in Amsterdam, and he's also the head of the pediatric endocrinology department. Professor van Trottenburg is also the director of the master program, the clinical internships in the Faculty of Medicine and the University of Amsterdam. And his research topics focus actually mainly on newborn screening and molecular elucidation, primarily of central congenital hypothyroidism. Paul, the stage is yours. Thank you very much.
The title of my talk is Central Congenital Hypothyroidism. I have nothing to disclose. And the first question, I think Nadia already addressed, the thyroid axis. The first question is, what is central hypothyroidism? Well, by definition, it's thyroid hormone deficiency due to insufficient stimulation by the hypothalamus or pituitary gland of a normal thyroid gland, and that's the big difference. But the result with respect to thyroid hormone is the same. In the blood, you measure a too low serum thyroid hormone level, so a low serum VT4 in the presence of a normal TSH. And that's the big difference between, of course, primary congenital, primary hypothyroidism and central hypothyroidism. So the next question is, what is central congenital hypothyroidism? Well, it's thyroid hormone deficiency due to pituitary or hypothalamus problems with a normal gland present at birth. And looking at central hypothyroidism, I think it was nicely stated by Paulo Beck-Beckos and colleagues already in 2017 that it's a rather neglected thyroid disorder. And this has everything to do with the way we approach persons that we suspect of hypothyroidism. TSH is almost always the first diagnostic test we do. And of course, that only diagnoses primary hypothyroidism. So this is one of the main problems when you suspect a person, a child, an adult of hypothyroidism. And if you consider central hypothyroidism, you should combine it with VT4 measurement. And this also applies to central congenital hypothyroidism. In the next 15 to 20 minutes, I will focus on 3 or 4 big topics in the area of central congenital hypo. That's the newborn screening, the causes of central congenital hypothyroidism in general, and in the children detected by newborn screening. We in the Netherlands have quite effective newborn screening, not only for primary congenital hypothyroidism, but also for central congenital hypothyroidism. Its clinical presentation and other endocrine abnormalities when detected in the neonatal period, and the outcome of early detection and treatment, and that's especially our experience in the Netherlands. So with respect to the first topic of my talk, the newborn screening for central congenital hypo, it's good to go back in history, because if we look back at the history of newborn screening, the first and primary goal was early detection of severe congenital hypo, and that's mainly severe primary congenital hypo. And as you may know, newborn screening for congenital hypothyroidism started in Canada in 1974 as a total T4-based screening approach, but that was quickly reformed into a T4 reflex TSH or T4 and TSH approach. And this enabled our Canadian colleagues in the 1970s not only to detect primary congenital hypothyroidism, but also central congenital hypothyroidism. But one of the problems in those early days was that there were quite a number of false positive NBS newborn screening results, example given due to thyroxine binding globulin deficiency. And if you look back at the early papers written in the 70s about the newborn screening, in the first year of this screening, they found 600 false positives in a total of 80,000 tested newborns, and that was approximately 0.75%. But yet, in the 1970s, by Dussault and his colleagues, it was judged as acceptable because it enabled detection of central congenital hypothyroidism. Yet, because of the high number of false positive NBS results in other countries and also in Canada, at a certain moment in time, new newborn screening programs were TSH-based only, and existing programs switched to TSH-based. And this meant that these programs only detected primary congenital hypothyroidism. If we look back at the Netherlands, we started screening for congenital hypothyroidism in 1981, and we started as a total T4 reflex TSH program. TSH measured in T4 concentration that was smaller than -2 standard deviations. And of course, in the early days of our screening, we also had a false positive problem. And the question was asked, why shouldn't we also switch to TSH-based screening? And then I have to, looking back now, thank my 2 predecessors in our department, and that was Thomas Vulsma, pediatric endocrinologist, and Professor Jan de Weiler, professor of thyroid biochemistry, who concluded that screening for central congenital hypothyroidism is worth the effort. And on the right side of the slide, you see a page from the PhD thesis of my former colleague, Professor Dr. Thomas Vulsma. And in the first 2 years of our screening, in the screening program, we detected 12 children with permanent central congenital hypothyroidism. And those children were diagnosed early and treated quite early, not as early as nowadays, but they were detected early. And based on the early evaluation of the screening, it was still considered a worthwhile screening. And if we then go back to 1976 in Canada, to a paper written by Dussault and colleagues in 1976, they also concluded that although TSH measurement in filter paper blood spots with low T4 concentration enabled earlier detection of primary congenital hypothyroidism, they stated that although it's a effective strategy, it's not a reason to only measure TSH, because they also found and they also deemed that detecting babies with central hypothyroidism was worthwhile. Yet Canada also switched to TSH-based strategy only. Of course, we had and still have a false positive problem, but we have reduced the number of false positives by having a special strategy for premature born infants who have a low T4 because of their prematurity. We adapted the T4 cutoff and added TBG measurement. We have a separate approach for late screened infants who have lower T4 values. And we adapted the TBG concentrations that in low TBG values, if they are measured, we don't refer children anymore for further workup. So looking now at our program, we have a quite effective and cost-effective program in the detection of primary as well as central congenital hypothyroidism. And nowadays, only in a few other countries, states or regions, the screening program detects central hypothyroidism. That's in regions in Italy, regions in Japan, one region in Spain, and several regions and states in the USA. Looking at the yield of our screening program in the Netherlands, we have approximately 17.5 million inhabitants with 180,000 live births. And of these 180,000 live births, 250 newborns have an abnormal NBS result. And 70 of them, approximately 70, have primary CH, and 6 to 10 have central CH every year. And it brings the number of true positives in our screening to 1 in 2,308. And the number of false positives is approximately 1 in 170. And that means we have a false positive rate of approximately 0.96%, and that's considerably 8 times lower than the rate that was found in Canada in the 70s. So we do much better than in Canada, but we haven't solved the false positive problem yet. But still, we find it a worthwhile screening. So then going to the second topic of this talk, the cause of central congenital hypothyroidism in general and in children detected by our newborn screening program. Well, the largest group is TSH deficiency as part of multiple pituitary hormone deficiency, or abbreviated MPHD. And if you look at the children with MPHD, you have syndromic forms, and those are multiple pituitary hormone deficiency combined with dysmorphic features like midline defects, eye abnormalities, holoprosencephaly, etc. And we have the non-syndromic MPHDs. And in our yield, it's especially children with pituitary stalk interruption syndrome and a few children with MPHD without pituitary malformations. And the minority is children with isolated TSH deficiency, but we detect them by our screening. And we published in 2020 a paper describing the clinical and genetic characteristics of Dutch children with central congenital hypothyroidism early detected by neonatal screening. And we did a study on these children in which we looked back in time, and we did a study on the period that spanned between 1995 and 2015, covering 20 years. In this period of time, almost 4 million babies were born, and most were screened by our system. And in this period, we detected 154 children with central CH, of whom 148 had terminal central CH, giving an incidence of about 1 in 25,000 children. All children and parents were approached for parent participation in this study via their attending pediatricians, and we did medical chart reviews, and we the children who were entered the study were invited to do for a study visit to our hospital. And here you can see the flow chart of the children that we knew existed and the number of children that participated in the study. In total, 154 children with permanent congenital central congenital hypothyroidism in this period, and 92 entered the study. And if we look at the causes of the total group of children that had permanent central congenital hypothyroidism, 63% of the children had multiple pituitary hormone deficiency and 37% had isolated TSH deficiency. Then of the children with multiple pituitary hormone deficiency, the majority had pituitary stalk interruption syndrome, and the minority had syndromic multiple pituitary hormone deficiency. Looking at the genetics, if we look at isolated TSH deficiency, we have 5 known genetic causes, and those are mutations in the genes encoding TRHR, TSH beta, IGSF1, and TBLN1X and IRS4. And Nadia Schoenmakers wrote a beautiful article in 2015 and made a beautiful picture where these genes are active in the hypothalamus and pituitary, but the talk is too short to go into detail for these, but I can really encourage you to read the paper by Nadia and her colleagues. Looking at our series of patients, we found a genetic cause of the isolated TSH deficiency in the majority, 91%. Most of the children in our study had mutations in IGSF1, and a few others had mutations in IRS4 and 5 in TBLN1X, and the minority had TSH beta or TRHR mutations. In only 3 children, no cause was found. So we could explain the majority of children with isolated central congenital hypothyroidism. In this study, we did not routinely conduct genetic testing in children with multiple pituitary hormone deficiency because, as you may know, monogenetic causes of, for instance, pituitary stalk intrusion syndrome are extremely rare, and in general, in children with MPHD, pathogenic variants are only found in 5 to 10% of patients. So we didn't do it routinely, and we didn't also do it for this study. Then going on to the clinical presentation and other endocrine abnormalities in the children that we evaluated for our retrospective study. A third interesting thing is looking at the VT4 concentration at the first diagnostic measurement. In general, children with central congenital hypothyroidism, if we detect them by neonatal screening, are seen first by a pediatrician or a pediatric endocrinologist around the age of 13 days. And that was almost the same for children with central congenital hypothyroidism as part of MPHD, and for the children with isolated central congenital hypothyroidism around the age of 14 days. In the children with MPHD, the mean VT4 concentration at diagnosis was slightly lower than in the children with isolated central congenital hypothyroidism, 8.7 versus 10.4 picomoles per liter. And it is good for you to know that if you look at neonates, the VT4 concentration in young neonates should be considerably higher than in older neonates and children beyond the neonatal period. And in the assay that is mostly used in the Netherlands, the lower limit of the reference interval for VT4 at the age of 14 days is around 15 picomoles per liter. So 8.7 and 10.4 are really lower than normal. In those children, we also looked at the age at which treatment was started, thyroid hormone treatment in the children with central CH as part of MPHD. It was around the age of 17 days, a few days after the first diagnostic measurements. And in the children with isolated central CH, it was slightly later, but still within the neonatal period. Looking at neonatal health problems, interesting to see was that of the children with central CH as part of MPHD, 88% was hospitalized prior to the abnormal neonatal screening result. So the majority was hospitalized, and only 31%, but also quite some children with isolated central congenital hypothyroidism were hospitalized prior to being detected. But the interesting thing was that only 5% of the children with multiple pituitary hormone deficiency were diagnosed with central CH prior to the abnormal neonatal screening. So in the majority of children, the neonatal screening that was abnormal was the first sign that there might be something wrong. And those children had other problems. For instance, in the children with MPSD, quite a lot had hypoglycemia and and the glucose levels in those children were quite low, 1.2 on average in the children with MPSD, and a few children with isolated central CH, and that's peculiar, but they had, and it was often the result of this maturity had also lower glucose levels. And another interesting thing, of course, and you know that there was micropenis in males, in almost half of the males with multiple pituitary hormone deficiency, but yet it was not a clue during hospitalization to that there might be a pituitary problem. If we look at other endocrine problems in these children, after follow-up and through diagnostics, the majority of children with MPSD turned out to have growth hormone deficiency, almost 100%. Almost 90% had ACTH deficiency, and 3/4 of the children had gonadotropin deficiency. And of course, in the isolated children, that was not the case. Although there was one child with IGSF-1 deficiency in the isolated central CH group that also had temporary growth hormone deficiency. Like I already said, in the majority of children with MPSD, there was pituitary stalk interruption syndrome, and that was diagnosed by brain MRI. Then looking at the final part of my talk, the outcome of early detection and treatment, and that's of course worthwhile to know, is that we also conducted in this visit to the Amsterdam University Medical Centers, we did cognitive and motor testing. And the children that entered the study, and those were 52 children with non-syndromic MPSD and 35 with isolated TSH deficiency, we conducted the Wechsler intelligence test and subtest, and we evaluated motor development by the motor assessment and battery for children checklist. And we used siblings, healthy siblings, as controls to compare them with age and social circumstances controlled children. If we look at the clinical characteristics of patients and controls and the socioeconomic comparison for patients and siblings, of course, they were normal because they were family. But for, of course, when we compare the clinical characteristics of the MPSD patients with the isolated central congenital hypothyroidism patients, and as I already mentioned, the children with MPSD had slightly lower 3T4 values on average as the isolated central congenital hypothyroidism patients. And of course, the children with multiple pituitary hormone deficiency had other endocrine abnormalities compared to the children with isolated central congenital hypothyroidism. But here you see a figure of the cognitive outcome, the full scale IQ. And it's a graph in which in the first column you see the cognitive outcome with on the y-axis the full scale intelligence quotient of all patients, MPSD combined with isolated central CH. The second column is the children with MPSD, and the third column is those with isolated central congenital hypothyroidism, and the fourth are the siblings. And as you can see, the children that were with isolated central congenital hypothyroidism that were early detected in treatment had comparable IQs to the siblings. IQs of 98.2 compared to 98.6. The children with multiple pituitary hormone deficiency did less well. They had an average IQ of 90.7. And if you look at the percentage of children that had an IQ below 70, in the isolated central congenital hypothyroidism compared to the siblings, that was around 2%, and in the children with MPSD, it was around 13%. But still, okay, compared to results I will show you in clinically detected children. An interesting outcome was processing speed. We know that processing speed can relate to intrauterine hypothyroidism. And the interesting thing that in siblings, the processing speed was around 100, but both in the MPHD group and in the isolated central congenital hypothyroidism group, the processing speed was lower than normal and comparable in both groups. And that might point to a effect of prenatal suboptimal thyroid hormone availability. When we looked at motor function, and all children, those with MPHD and isolated central CH were tested. Of 24 children with MPHD tested for motor function, 8 had difficulties, and in the isolated central CH group, it was 5 out of 15. In both groups, approximately 1/3. In the siblings, it was only 1, and that also might point to the importance of thyroid hormone in the fetal development of the brain and showing motor difficulties later in life. Then, as last slides, how about children that were clinically detected? And one of the only studies that has been published on this was conducted by Todd Nebesio and colleagues from the US. And they did an evaluation of all children diagnosed with central congenital hypothyroidism with no neonatal screening results over a period of 16 years between 1990 and 2006 in Riley Hospital for Children in Indianapolis. They retrieved clinical and diagnostic data, and they looked in the charts if there were development problems, yes or no. They were able to identify 52 children with central congenital hypothyroidism, of which 42 children were analyzed. 41 of 42 had multiple pituitary hormone deficiency, the vast majority, and only 1 had isolated central CH. And in those children clinically detected, 8 of 42 had an abnormal newborn screening result, and 34 of 42 had a normal screening result. And they do the T4 plus TSH testing. But if you then look what they found of the children who were diagnosed with central congenital hypothyroidism, with the vast majority having multiple pituitary hormone deficiency, developmental delay was reported in 50%. And the article didn't mention how bad the developmental delay was, but this seems to be considerably higher than in our study, in which we find an IQ lower than 70 and only 13%. Concluding with our results, I think we can state that central congenital hypothyroidism can be effectively and cost-effectively detected by MBS. We found that the children we detected, 2/3 had MPHD, 1/3 isolated, and only few children with central CH were diagnosed with this condition prior to the abnormal MBS result. We find that children with isolated central CH, if they are detected and treated early, they are comparable to unaffected siblings, but children with MPHD do a little less well. And almost all cases of isolated central CH can be explained by pathogenic variants in the 5 genes I mentioned, but most cases of MPHD remain unexplained. We didn't dig into it, but most cases remain unexplained. And I think we need more research to better know the cognitive outcome in late detected central CH patients to draw the conclusion that this is an approach that should be done in other regions, other countries as well. Thank you for your attention.
Thank you very much, Paul, for this great overview of central congenital hypothyroidism. So we have some questions.
Someone asked me a question, but I made the wrong manipulation on the.
It's okay. I will just tell the question. So Dr. Rana Al-Musa is the first question for Professor Luton. So you mentioned hypothyroidism, I think fetal hypothyroidism, if the mother is treated by PTU with L-thyroxine. So she asked why if she is treated with thyroxine.
Because PTU passes so well the placenta that it will his action will be more potent than the few LT4 that passes from the mother. And in that case, you will overtreat the mother, give him add-back therapy, but only one will pass very easily the placenta and then will induce a fetal hypothyroidism. This is the best way to have fetal hypothyroidism. Do an add-back therapy to the mother.
Okay, great. Thank you very much. I just tell the second question is for Paula. Thank you for your talk. When diagnosing central hypothyroidism, what test do you use to diagnose corticotropin deficiency, central cortisol deficiency, because they don't have the circadian rhythm established? If you use ACTH stimulation test, if you use the low dose or the high dose test?
Thank you for your question. If we diagnose central hypothyroidism and diagnosing, or let's say confirming the diagnosis of central hypothyroidism is not always easy, because if a child is premature, VT4 can be a little low or borderline premature. Non-thyroidal illness is often a problem that we consider. But if we suspect a child of central hypothyroidism, defined as a too low VT4 for the age-specific reference interval in combination with a normal, slightly elevated of low TSH, we do the low-dose ACTH test. We don't do random cortisol measurement exactly for the reason that you mentioned, that they can be low in normal infants, and it doesn't tell us enough about the adrenal axis. So we do the low-dose ACTH test.
Thank you. Thank you very much.
Thanks, Paul. I think there's a third question, which is probably also directed to you by Pian T. With increased survival of premature babies, we see more hypothyroxanemia. How to differentiate transient hypothyroxanemia of prematurity from congenital central hypothyroidism? When shall we consider thyroid hormone replacement therapy in these group of premature babies? Thank you.
Shall I try to answer it?
I think so. Yeah.
Yeah, that's good.
Yes.
Well, when we started our screening, we had false positives, and we still had false positives. And in the early days of screening, we had a lot of false positives, especially in premature born babies. So what we do now is that we don't judge premature and born babies born before a gestational age of 36 weeks and having a birth weight lower than 2,500 grams. We don't judge them by their T4, but only by their TSH. So we detect only primary CH in premature born babies. If we apply the same strategy as in term born babies, we have really a vast amount of babies with an abnormal screening result, and that's too much. So we only aim for detecting primary congenital hypo in premature and born babies. So we don't find them. But your point is right. If you suspect a premature and born baby a few weeks old of central congenital hypothyroidism for whatever reason, then free T4 is a difficult value, because it can be low because of the immature hypothalamus pituitary thyroid axis. So then if we are in doubt, and if there's already no illness, also a cause of a low free T4, then we work up the baby with ACTH testing, low-dose ACTH testing. And if that's normal, then sometimes we follow free T4 until the term age, especially is free T4 not very low. And at a certain moment, we have to decide whether to treat yes or no. But premature born babies is a difficult group of children because of their prematurity and the frequent occurrence of non-thyroidal illness. I don't know if you have additions, Nadia or Tanya, about this topic, because it's a different category of children, a difficult category of children.
You want anything to add there, Nadia?
No, I think only just a second. I mean, as Paul has said, it's a really difficult diagnosis to make. And actually, even in non-premature infants, when the
True.
T4 is right at the lower
Yeah.
level of the normal range, it's that consideration of, is this normal? Is it sick? Is it non-thyroidal illness? It's very difficult. And we need more biomarkers, which at the
True.
moment, I don't think we have.
Not yet.
Yeah, totally agree.
Thank you. So the fourth question by Dr. Farah Yaha is for how long should we continue treatment if it's transient when it's transient in a neonate? Is that perhaps something to that you can start off, Nadia?
I can start. I'm not quite sure if I understand the question. I guess when I spoke about you only know that the hypothyroidism is transient when you
If
treat
you
it
can.
and stop the treatment. So by transient hypothyroidism in my talk, what I meant was a neonate who has congenital hypothyroidism, they're given levothyroxine, and then usually in the UK, usually before the age of 3, we would sort of reevaluate that child. What dose of thyroxine are they needing? Do we know what the underlying etiology is? If they've got a normal gland in situ, could we then try and wean down the thyroxine and see whether we can actually stop the medication and they remain euthyroid? So we'd normally do that sort of trial. Really, we're really sort of timing it for when that period of really high thyroid hormone biosynthesis requirements is declining to see whether the thyroid can cope. I'm not quite sure if that answers the question, but
And when would you typically start to taper down? What
So
age?
I think normally before the age of 3, and I think it depends on the dose of thyroxine. I should say I'm not a pediatrician, so that this is sort of theoretical, but we do, between the age of 2 and 3, if the thyroxine requirements are really low, then that's the time that we might consider it. So when the critical sort of period of brain development is past and the thyroid hormone biosynthesis requirements are declining.
Yeah, thank you very much. I leave the next question to Tanya again.
Yeah, thank you, Edward. So the next question is from Dr. Rana Alamusa. It's also for Nadia. If you could explain the perchlorate discharge test.
Sure, I had a slide in.
Thank
I
you.
should have left it in. So it's a test that's perhaps again in some senses it's used commonly, and in others it's not. But it's a test for assessing really those processes at the apical membrane of the thyrocyte that are involved in organifying iodine, incorporating it into the tyrosol residues on thyroglobulin. So the way the test works is that you administer a dose of radioiodine to the child, and after a time interval you quantify the uptake of that radioiodine into the thyroid. You then give perchlorate, which blocks the sodium iodide syn-porter and blocks further uptake of radioiodine. And then after a time interval, you quantify the amount of radioiodine that is remaining within the thyroid. And if those processes driving iodide organification are intact, then 90% of the iodine should remain within the thyroid, and there should be less than 10% discharged. So if you have more than 10% discharged after that time interval, that's said to be a positive test result. And there are different grades. So you can, depending on the amount that's discharged, you can categorize it as a partial iodide organification defect or a total iodide organification defect.
Thank you very much, Nadia. So the other question, I think we have already answered it. It's answered. It's always the same about transient hypothyroidism. So just one more question for you. It's about thyroglobulin level. Why it was low? I think it was about yeah. Thank you.
So it was a patient with a biallelic thyroglobulin mutation. It was a splice site mutation. So presumably the protein, again, we didn't characterize this in vitro, but I suspect the protein is synthesized and is perhaps either you get nonsense mediated decay or perhaps it's unstable. Essentially you're not getting a normal amount of thyroglobulin produced because of that biallelic mutation.
Thank you very much. Edward, if you can also read the last question.
Yeah, so the question from Rana Al-Musa is whether Prof. Luton, please explain the pathophysiology of the advanced bone age in hypothyroidism. And perhaps I can add a question from myself. I was also a bit struck is that heart rate doesn't seem to respond that much to the thyroid state. Certainly not to a low thyroid state, but if I recall correctly, you said tachycardia is a late sign. So could you kind of discuss the differences in different tissues on thyroid state?
Okay, for the first point, well, even in uterine life, thyroxine will accelerate bone maturation. So, well, it's a physiological fact. It's just because it accelerates differentiation. So, well, if you've got a fetus with high level of T4 or T3, it will accelerate its maturation. I don't have much than the pathophysiology of telling you that I don't know the receptor which is involved in this case, but it works. For this, is it okay for this answer, or you want more?
I'm unsure, but I think maybe go on, and we will see in the chat if there's further.
The second thing is that in fetal hypothyroidism, once you have tachycardia, the whole I've seen, it's a sign of a cardiac failure which could happen, or intrauterine fetal death. So I said it's a late sign because it's not always present at the beginning of the syndrome. Maybe because you don't have, for a single fetus, the level of the fetal heart rate at beginning. See what I mean? If the fetus is at 150 per minute, if it was his rate level, okay. But if he was before at 130, you didn't know about that. So you can't just see the difference. But when you take, when you see his hypothyroidism, so you just have to see the heart rate. And then if you see a modification and acceleration and more over 160, it is a sign that there is a real, just like a fetal thyrotoxicosis. So it's for me, it's rather a bit late as a sign, and it's a sign which shows you that you have to monitor your fetus if you don't want to have a drama, okay? Second, for hypothyroidism fetuses, I did not observe at any time bradycardia. I don't know why, but maybe there is an ontogenesis of different receptor which induce this fact. On the same, if you, this is a non-published observation now, but if you look at fetuses which are under beta blockers from the mother, you don't see bradycardia even. So the bradycardia is not a sign of fetal hypothyroidism, but tachycardia is a sign of hypothyroidism and an emergency sign.
Thanks. Yeah, it's remarkable in a way because bone is a TR-alpha tissue and heart as well. So in some way, it seems the heart is less responsive to thyroid state in fetal life, only if there's very much of excess. Yeah.
Well, it's just observation. I don't have the.
No, but I think those, I mean, observations over a long time, I think that really count. So I certainly believe you. Let me see. I think, yeah, there are no further questions I see, and I think we're running a bit over time. So shall we? Is there anything else we should discuss?
I have one question.
Yeah.
Myself.
Okay.
You know, as we are trying to treat some hypothyroidism in utero, and often in this homogenesis, we don't succeed to have the right rate of T4 at delivery. And having learned what you said just now, I just wanted to know if you would consider that we should be more aggressive on the treatment or let it be like that.
This was also one of my questions because you said, Dominique, that we cannot normalize thyroid function test, so T4 for babies with anti-amniotic injections, isn't it? With
Yes, it was a
L-thyroxine.
paper a few years
Yeah.
ago.
And we can not even normalize, but we can stabilize the thyroid size, isn't it?
Yeah. Yes, this is what I said.
And why can't we normalize even the thyroid size? Because it's not enough, the injections or the dose or the frequency, or I don't
Because
know.
as long as we have to inject in utero,
Yeah.
we try not to inject too often because there is a risk of chorioamnionitis. So we found a sort of how do you say agreement to inject every 15 days, the whole dose for 15 days. But maybe from a pharmacological point of view, this is not the best, but we have not got better right now.
Okay.
So
So
perhaps,
other option would be to inject more, would be to deliver from a different way.
Yeah.
We've got some solution also.
or perhaps increase the frequency, but because I think a type 3 deiodinase, so the enzyme that degrades T3, but also
T4, yeah.
T4 is very highly has a very high expression in fetal tissues, placenta. So maybe if you give it weekly, the majority is already degraded after 1 or 2 days. I don't know.
Dominique, can I ask another question to you? Is it possible?
Yes,
Just
of
a short
course.
one. Do you know if there are any studies, because I haven't looked at them, who looked at if it's useful to combine intra-amniotic injections with also treating the mother, or
Okay.
giving the mother a free T4 around the upper limit of the reference interval, of even a bit higher, that the combination might lead to a on average higher T4 concentration in the fetus.
We know that when the mothers are under PTU and have a normal but low value of T4,
Yeah.
if you lower the PTU and increase, of course, the T4 in the mother, you improve the things. So giving the optimal amount of LT4 to the mother will help, of sure.
Yeah.
But I don't know if you have to go above the normal. See what I mean?
Yeah, me neither. I don't know either. No.
And because we have had some studies who showed that an overload of LT4 could be also harmful, I try to stand in the normal range in the upper limit.
Yeah, can imagine. Yeah. Thank you.
So maybe we can discuss the last 2 questions. So I think Dr. Musa added a comment to the question on the advanced bone age, because as levothyroxine therapy is associated with osteopenia or osteoporosis in adulthood. Yeah, so maybe,
She's right.
yeah. So probably that's the difference between development and adult life.
Yes, we have found some difference, and this is another one.
Yeah.
Okay. Tanya, do you take the last one?
Yes, and the last question is for Paul. So from Dr. Afis Ahmad, how high of TSH can be seen in central hypothyroidism? How high can be the level of TSH?
Yeah, that's a very good question. And the highest value we encountered was between 12 and 13. So a really a too low T4 concentration in combination with a TSH of 12 to 13. And I asked this same question to Mehul Dattani, Great Ormond Street, London, what his experience was, and his experience was below 15, not higher than 15. So I think that's a value to keep in mind.
Okay, great. Thank you very much.
So thank you very much to everyone, particularly to the three speakers, to Dominique, to Nadia, to Paul for excellent presentations, also for the lively discussion. Thanks very much to all the participants. I noted that a maximum of 160 participants were present, which is a very high number. So thank you all for participating, for sending in questions, and we wish you a pleasant evening. Thank you.
Thank you very much.
Thank you very much.
Thank you, Edward and Tanya, for hosting the meeting because
Yeah.
it was a nice meeting. Thank you.
It was a
Thank
nice
you very
moment.
much.
Thank you.